calorie restriction and so on, found many metabolic benefits, but he was not able to see any significant reduction in EGF-1. Conversely, when he studied this group of patients, a little bit fanatical, these are vegetarians who eat only raw food, and he compared them with other groups, other populations. Vegetarians who eat raw food only have a very poor diet. It's not easy to overeat protein if you only eat raw vegetables. And in fact, their proteins were 9% of the total calories, whereas in the normal American diet, it's 17%. Anyway, in this group, he found a reduction. Everything that's in yellow is statistically significant. Anyway, he found a dramatic reduction in the levels of IGF-1, and then you can see the various levels of C-reactive protein, etc. So, to also reduce IGF-1 levels, you have to also reduce dietary protein. We probably eat twice as much protein as we need, according to the World Health Organization, which talks about 8. We should be above 8% of total calories coming from protein, because it's controlled by growth hormone, which is controlled in turn. Protein has an effect on liver situation, and even the production of the activation of MTOR by the IGF-1 insulin signaling pathway requires amino acid sufficiency, and autophagy is inhibited by high levels of amino acids. Hence, we should meditate on including less protein in our diet. Our EPIC study in this cross-sectional trial shows that CF1 levels are related to protein in diet, IGF-1 associated with dietary protein, and all of the participants in the EPIC protein eat too many proteins, and they are related particularly to milk proteins. Milk contains IGF-1. It induces IGF-1 synthesis. Milk is obviously food that makes people grow. And studies on breast cancer and diet have been very difficult to conduct, whereas for intestinal cancer, our prospective trials gave great satisfaction relating to the consumption of meat, preserved meat, fiber, a relationship with calcium, intake, vitamin D, etc., etc. For breast cancer, it's very difficult to exactly see the role of the different nutrients. And it was only when we began looking at data, not in terms of individual foodstuffs, but in terms of dietary patterns, that we and our colleagues in 2004 began in our study on 11,000 women to see that the pattern was characterized by what they called the salad olive oil pattern. The consumption of vegetables, cooked and raw, and olive oil, and that's typical of the Mediterranean diet, was significantly related to risk reduction, particularly for ER2 tumors. These are other studies. Some specifically worked on Mediterranean diet markers, and the studies were very consistent in finding that there was protection. Anna Wu's study was interested because she looked at the Mediterranean diet in the Chinese populations of California, and the Mediterranean was defined as follows. She divided the population into two. She gave a score to women who were in the higher 50% for the consumption of cereal, another point in the 50% higher group consuming legumes, vegetables, fruit, fish, etc. She didn't include olive oil because it still isn't widely used by the Chinese populations, and a negative score for people in the higher 50% for consumption of meat, fish and milk, sugars and alcohol, although moderate consumption of alcohol is part of the Mediterranean diet traditionally. She found, in fact, that those that had a high score for the Mediterranean diet in this population had a risk of 2/3 of developing breast cancer. We're working with on a randomized trial. We've decided to embark on a very important study, randomizing 2,000 women at high metabolic risk for developing 2,000 patients who've had breast cancer at high risk for metastases, and we're halfway through the study. It's being conducted in Milan, Turin, Pescara, Potenza, Naples, and Palermo. We're still in the process of enrolling half of the patients, and over 5 or 6 years we'll know whether it is possible to modify the risk of metastases in relation to a radical change in diet and lifestyles, because it's not just food but also an increase in exercise. There are many observational trials in this subject, but we need experimental studies that have not yet been conducted, and this is one of them. Not this one and not this one. I think I've messed up my slides a little bit, as always, because I always forget to remove the slides I don't want to show. This is another study that's being started up at an experimental stage. We're looking at enrolling 16,000 healthy women. We want to look not only at a changing lifestyle, diet and exercise, we also wish to use a drug, metformin. Metformin is a drug used for the last 50 years for treating diabetes and for preventing diabetes. It's a safe drug, although there is a hypothetical risk of lactic acidosis in people who have renal insufficiency, renal failure. You have to be very careful on that to assess the general health of the patients, of the people. The study will be randomized, factually randomized. One group will have a particular diet and exercise and will take metformin. Another group will take only metformin. Another group will have only diet and exercise, and a group will only be the placebo group. The metformin part will be in double-blind. The diet and exercise group cannot be double-blind, obviously. The study's begun. We're recruiting women, and our advertising says measure your waistline, and if it's more than 85 centimeters, you can participate in the trial. And we'll see over the next year or year and a half what the metabolic effects will be on the 4 groups, and we'll also see in about a year and a half whether we'll have funding to enroll the 16,000 people. Thank you.